Hi, welcome to today's topic. It is assisted breech delivery. Let us discuss about breech, how it happens naturally or spontaneously, and how should we assist it to prevent complications. Before going to the mechanism, let us know briefly about what is breech presentation. Breech is one of the commonest malpresentation. As we already discussed, the part of the fetus which occupies the lower pole is presentation. So, if the buttocks are down, then it is breech presentation. If the head is down, then it is cephalic presentation. If it is a transverse lie, then shoulder becomes the presentation. We should remember the incidence of breech is not throughout the same. Initially in preterm pregnancies like at 28 weeks or 34 weeks or 32 weeks, whenever you examine, most commonly you can find them as breech presentation, as much as 25% at 28 weeks to 5% at 34 weeks, because the baby moves, it keeps rotating. But by the time they come to term, the incidence is only 3%. So, as high as 25% at 28 weeks to as low as 3% at term. So, only 3% patients come to us with breech presentation in labor. Buttocks in the pelvic brim, mostly longitudinal. It can be oblique also, but it will be mostly longitudinal. We already discussed in the previous session or in a normal labor session where we told about what is lie, what is presentation, what is presenting part, all these things. You can revise there once if you want. What are the different types of breech that you know? This is a place where the hip joint is flexed but the knee joint is extended, and it is quite favorable for breech delivery. This is frank breech, okay? Whereas this is a place where the knee joint and the hip joint both are flexed, and this is a complete breech. As mentioned, flexed hip and flexed knee. In this case, you have favorable for external cephalic version. Whereas in incomplete, it can be either frank breech or like this. It is a footling presentation where it is partially extended at hip also and partially extended at knee also, as you can see in the photo. So, these are the different types of breech. In frank breech, it is extended only at knee but flexed at hip joint, whereas at knee presentation, it is partially extended hip also and partially extended at knee also. You can keep it for yourself and you will get to know. If you flex at knee and at hip joint, then it is a universal flexion, that is complete breech. Whereas if you extend at knee, the limbs come to your face like this, that is frank breech. Whereas in footling, it is extended at both the places. What are the predisposing factors? Why should someone present with breech presentation? If 96% population is presenting with cephalic presentation, why only few patients are presenting with breech presentation? The most common is prematurity. As we already told, the incidence is almost 25% at 28 weeks period of gestation, isn't it? So, if they are premature delivery, like preterm delivery is not most common malpresentation will be breech delivery. And multiple gestations. See, the both breech cannot occupy at the fundal pole. The space is less. So, head occupies less space. So, one twin occupies the breech in the fundus and the other twin occupies head in the fundus. So, the other twins buttocks come down, causing breech presentation in the lower pole. So, multiple gestation, most commonly one twin will have breech in the lower pole. Both cephalic is also there, but the space or over distension is more. Oligo or polyhydramnios. What happens here is, in polyhydramnios, the liquor is excess. So, the breech the baby keeps on moving and breech comes down, and the position of presentation cannot be still, so because of the excess liquor. So, even at term you can find breech as the presentation. Whereas in oligo, what happens? Baby's buttocks would be down and the liquor is reduced and baby is not able to move back to its fundal position, breech at the fundus. So, even in oligohydramnios you can see cases of breech presentation. Uterine anomalies or fetal anomalies. In such cases, like malformations of the uterus. Why breech occupies the fundus or the buttocks occupy in the fundus is because fundus is broad and the buttocks are broad. So, it gets more space to occupy. That is why usually buttocks are at the fundus. But what happens in case of arcuate or septate uterus? there is less space because of the deviation. There is less space, buttocks cannot fit there, so they try to come down. That becomes a breech presentation. Whereas in fibroids also same thing, fibroids come at the fundus and there is no place for the buttocks to stay there, so it will come down. Whereas in fetal abnormalities like CNS malformation or neck mass, imagine baby is having a neck mass and baby's neck cannot be flexed well. That time what happens, baby cannot be moved, or baby will not have enough space in the pelvis because pelvis is small, so it tries to go to the fundal position. So head comes to the fundus or breech comes to the lower pole, it both becomes breech presentation or previous breech delivery. And also they have tendency to develop breech presentation in this pregnancy. Diagnosis. How do we diagnose this? Firstly, by the Leopold's maneuver. Anything is asked how do you diagnose, you should always start with history or examination. So in examination, how do we find it is breech presentation? Firstly, in a Leopold's maneuver, first grip, what is that? It is a fundal grip. When you do a fundal grip, you will not feel the breech there, you will feel the head. If head is in the fundus, that means breech should be in the lower pole. Okay, in fundal grip, you will feel head. Or when you do the pelvic grips, what happens? When you are feeling at the pelvis, it is not head that you're feeling the buttocks. Okay, that is how you will get to know that it is breech presentation. Or also you can remember when you hear for the FHS or fetal heart sound, when you auscultate, that time in breech it will be close to umbilicus and above the umbilicus, whereas in cephalic presentation it will be below the umbilicus. These are the 3 points that you should tell in examination. How do you find breech as the presentation? Firstly, in fundal grip you will find head, in pelvic grip you will find the breech. Thirdly, in auscultation you will find FHS or fetal heart sound above or close to the umbilicus, whereas in cephalic, auscultation of fetal heart sound is below the umbilicus in a spino-umbilical line. In pelvic examination, when you do an internal examination, what happens? You can feel the fetal buttocks. Sometimes people get confused with breech presentation to face presentation. Why? Breech, the sacrum is felt like your malar prominence. Okay, so malar prominence and mouth is felt like anal opening. How do you differentiate between face presentation and breech presentation? This is how, where in face the malar prominence and the mouth, opening of the mouth forms a triangle, it will not be in a line. Whereas in internal examination of breech, the sacral prominence and the anal canal forms a straight line. That is how you will differentiate between face and breech presentation in an internal examination. Of course, ultrasound is the confirmatory and commonly done investigation for all pregnant patients, and that gives a exact or confirmatory investigation to say it is breech presentation. Previously, long ago, they used to do X-ray as shown in this photo. You can see the fetal spine, fetal head. This is the buttocks occupying the lower pole. But nowadays, we do not do. No more practiced in modern obstetrics. Management. If you find a patient at term gestation or in labor with breech presentation, how do you manage? And how do you manage if she is not in labor or she is early preterm like 36 weeker, late preterm like 36 weeker, how do you manage? For example, if she is late preterm and not in labor, you can definitely try for external cephalic version. External, when you're doing outside, from the outside, and cephalic, you'll try to move the head down version, head down to the lower pole and breech you'll pull back to the fundus. Okay, success rate is around 60 to 70% alone. Though we can try it, but the success rate is only 60 to 70%. External cephalic version will be dealt as a separate topic where you will find whom all you can do, what is the success rate, what are the favorable conditions, what are the risks of doing that, and why you should do it and why you should not be doing it. That is dealt in a different class. Vaginal delivery can happen in breech. Not every breech delivery goes for a cesarean section. No, illa. Vaginal delivery can be spontaneous, assisted breech or total breech extraction. Spontaneous we would not prefer, assisted breech we prefer, and total breech extraction also we would not prefer. This happens only in cases of second twin which is breech and you want to extract it, and really not done. Or spontaneous breech unless until nobody is there to monitor, or partial or assisted breech is what we generally do. Cesarean section electively for a primi gravida we do. For most of the cases of breech delivery goes for cesarean section because of the difficult delivery of the head. Head is most difficult to deliver and it comes in the end. You do not have any choice that time, so cesarean delivery is commonly done for breech presentation. breech delivery is spontaneous. As we already told, no manipulation, assistance of infant is necessary. Only after the delivery it is necessary. But we rarely do, as I already told, because when there is nobody to assist, maybe that time at home or somewhere in PHC, somewhere it might happen, but that is what we do not prefer at all. Whereas assisted breech, where we assist the fetus, okay, spontaneously the fetus is delivered until the umbilicus, okay, is seen at the vagina enteroitus. Then the fetus is delivered by assistance. Breech delivery should always remember, you should never push or pull, okay, you should gently assist it but never push or pull. Total breech extraction, the entire fetus is extracted without maternal effort. This indicated only for second twin delivery. This is also rarely practiced in modern obstetrics. Condition unfavorable for breech delivery, where all you should not try for breech delivery. When the baby weight is more than 3,500 grams, if a baby is more than 3.5 kgs, the head is definitely bigger and it will get stuck, because breech is something which can undergo compaction or it can be compressed, and breech can come out even before the full dilatation of cervix, but head cannot do that. So head will get stuck and it is very difficult to deliver later. So if the baby is more than 3.5 kg, if you feel, you can take for an elective cesarean only. Unfavorable pelvis, even being a cephalic presentation also, if they have contracted pelvis, it is for an elective cesarean only. Like platypod and android pelvis, breech delivery does not allow sufficient time for molding of the head, so you should not preferably do in such cases. Hyperextension of the head. What happens in such case? The diameter, it occupies the manubrio-cortical diameter, and which is 18 centimeters, and it cannot come out of the, in none of the pelvic diameters are as big as that. So if the head is extended, and then the breech can never be delivered, okay. So then the head gets stuck. When the head is extended in a breech presentation, it is called a star-gazing appearance, okay. The head is called star-gazing. Knee or footling presentation, there is chance of umbilical cord prolapse, as high as 17% in footling presentation. In footling presentation or knee presentation, we never try. As you know, foot is so small, and even with 3 or 4 centimeters dilatation, it will prolapse. Along with that, cord will prolapse. So what happens? There is no enough dilatation for the delivery of buttocks also, or the delivery of the head also. So we will never try breech delivery in case of footling presentation or knee presentation. Hence, do elective cesarean section. In complete breech, the incidence of cord prolapse is 5%. This incidence and all, they will ask you in viva voice. You should, if you have answered all the basic questions, here is what they will catch you on. If you answer these, then they will give you the maximum marks. Frank breech, the incidence is very less. So frank breech is most preferable for assisted breech delivery or vaginal delivery. Complications of breech vaginal delivery. If you force any patient, or if any breech delivery happens, then the complication is increased morbidity, because the time is so more than cephalic presentation, because breech would not dilate the cervix as easily as that head can do, because head is more of hard surface and dilatation is slower and extraction is long and the baby is suffering. The morbidity is high. Trauma, tears on the cervix and vagina is really high, and also increased operative deliveries like forceps you apply, or you will do more of assistance, extended episiotomy you will be giving. So operative deliveries, cesarean you will go for, all are more common, and hence the trauma is more to the mother and also to the fetus. As you can see in the photo, if you do not pull it out properly, then it can have fractures also. Increased mortality and morbidity of the fetus. Almost all the babies that deliver of breech will have low Apgar. That is what is noted. Apgar score also you should be knowing. Birth trauma, fracture clavicle, humerus, femur, as shown in this photo also. Birth asphyxia is quite common, and cord prolapse is a dreadful complication. Now let us begin with the mechanism of labor. In breech, the mechanism of labor happens at 3 places. Firstly at the buttocks, then at the shoulders, and then at the head. Okay, these 3 places there is all the steps. As you learnt in normal labor, the same steps happen, but it happens at 3 places. First the buttocks come, so it happens at the buttocks, then at the shoulder, then at the head. So I'll show you mechanism of breech delivery in case of a frank breech. Okay, this is a frank breech where the hip joint is flexed and the knee joint is extended. So the foot is near the face. Okay, the hip joint is flexed and the knee joint is extended. Now let us begin with the mechanism of labor. As we read about left occipito-anterior, the same way we will read about left sacro-anterior mechanism of labor. Left sacro-anterior, this is the sacrum, this is the left side, and the left it is sacro-anterior. Understood? So, left sacro-anterior as the position of the fetus. We are explaining the mechanism of labor. It happens at 3 stages, that is at the buttocks, at the shoulder, and at the head. So, anytime when you ask breech presentation to show, you should always show it start it as mechanism of labor in breech presentation happens at 3 places, that is at the buttocks, at the shoulders, and at the fetal head. Okay. Engagement is when the bitrochanteric diameter engages or enters into the pelvis, that is it enters in the left oblique diameter, that is around 12 centimeters, and your bitrochanteric diameter is around 10 centimeters. When it crosses the pelvic brim, it is called head breech is engaged. When the breech is engaged, and then further with good uterine contraction, there is descent of the breech and also there is compaction of the breech. Next is internal rotation of the breech. What happens here? Once the breech touches the pelvic floor, then it rotates anteriorly. For example, the anterior buttock touches the pelvic floor, and then by Hart's rule, it rotates anteriorly by 1/8 of the circle, and then the anterior buttock hinges behind the pubic symphysis. Anterior buttock touches the pelvic floor and rotates 1/8 of the circle. This is how it entered in an angle of left oblique diameter, and then it entered and got compacted, and the anterior buttock touched the pelvic floor, and then it rotated anteriorly by 1/8 of the circle, and then the anterior buttock is hinging behind it touched the pelvic floor, rotated anteriorly, and the anterior buttock is hinging behind the pubic symphysis. Okay, this is internal rotation of the breech. Then the birth of the buttocks happen by lateral flexion, like this. Just like this, the birth of the buttocks happen. You can see this is in the photo. See, there is in this photo you can see the crowning. In breech, in head when we say it as crowning, in breech it is called as climbing of the breech. Okay, when the breech is seen, it is called climbing. Breech is climbing the pelvis. Okay. Breech climbs the perineum, and delivery of the breech happens by lateral flexion. The left sacro-anterior, the bitrochanteric diameter engages in the left oblique diameter, enters the pelvis, calling engagement. Then the descent and compaction happens, and then the anterior buttock touches the pelvic floor first, and then it rotates anteriorly by 1/8 of the circle, hinges behind the pubic symphysis, and delivered by lateral flexion. During this time, the shoulder gets engaged, that is the bisacromial diameter. The diameter between the two acromial process, that is around 12 centimeters, engages in the left oblique diameter. Breech is like this. So, breech is like this, and it is also engaging in left oblique diameter. So, it engages in left oblique diameter, and then it goes down. And then the anterior shoulder touches down, and then it also rotates anteriorly by 1/8 of the circle, and it also hinges behind the pubic symphysis, and delivery of the anterior shoulder and the delivery of the posterior shoulder happens. By the meantime, the head comes into the pelvis. Okay. Now the biparietal diameter, that is 9.5 centimeters, is in the left oblique diameter, and the suboccipito-brygmatic, which is the antero-posterior diameter, that occupies in the right oblique diameter of the fetus, and it engages into the pelvis. Okay. Then it touches behind, and then it also rotates anteriorly. It's like this. It touches the pelvic floor, it rotates anteriorly by 1/8 of the circle, hinges behind the pubic symphysis, and delivery of the head happens by flexion. See, you can show, it is shown in this photo, the bisacromial diameter, which is 12 centimeters, occupies the left oblique diameter, and then it causes descent and internal rotation, and then anterior shoulder hinges behind the pubic symphysis, and delivery of anterior shoulder, posterior shoulder. Meanwhile, your head is coming. head, anterior shoulder is born, engagement of the head happens simultaneously. Your biparietal diameter engages in the left oblique diameter and descent and flexion happens of the head. Internal rotation, subocciput hinges behind the pubic symphysis and delivery flexion of the head completes with the expulsion. Delivery of the head happens by flexion. Before going to assisted breech delivery, just remember, in breech the delivery happens at, or the mechanism of labor happens at 3 places, and the steps is as simple as engagement, descent and compaction, internal rotation and delivery. It happens the same at buttocks, it happens the same at shoulder, it happens the same at head also, but at head it undergoes flexion to prevent over diameters of the head. Okay, so engagement, descent and compaction, internal rotation, delivery of the buttocks. That time the shoulder is at the engaging diameter, a shoulder gets engaged, the bisacromial diameter is the one which is 12 centimeters, that also goes down, descent and compaction and internal rotation, anterior shoulder hinges behind and delivery of the anterior shoulder happens. Then the biparietal diameter, which is again occupying the left oblique, whereas in flexed head suboccipitobregmatic will be the antero-posterior diameter that occupies the right oblique. Don't get confused. All the transverse diameters will be in the same plane. If your buttocks, your shoulder and your biparietal is in the same plane, so everything should occupy your left oblique only. Only the antero-posterior diameter occupies the right oblique diameter. Okay, and then with good flexion, and then what happens? Internal rotation, occiput hinges behind the pubic symphysis and delivery of the head happens by flexion. Now let us see how to conduct an assisted breech delivery. This is complete spontaneous breech. Everything happened on its own. Everything came out on its own and breech delivered. How do we do assisted breech delivery? You should have an expert obstetrician, obstetric assistant, anesthesiologist, and also to give emergency cesarean section and neonatologist. As we already told, most of these babies go for low Apgar and NICU monitoring. Availability of pre-warmed towel, because the body is delivered first, it should not go for hypothermia. Once the body is delivered, cover the baby with the towel. That is how it helps. Okay, pre-warmed towel, so that hypothermia is prevented. Obstetric forceps, long forceps or Piper's forceps for the after coming head, and baby resuscitation trolley with suction, heater, oxygen drugs, whatever is required, an episiotomy trolley, because you preferably for any operative delivery should be giving episiotomy. Then you should give a IV line, wide bore needle, liberal episiotomy with local infiltration with consent, then suprapubic and fundal pressure only by the assistant during contraction. Never push or pull. As we already told, you should never push and never pull. Never push or pull. Okay, as we already told, because if you push or pull, then the baby will get extended and it can never be delivered. Okay, that is why never push and pull. And the obstetric assistant, when they give a suprapubic pressure, it should be in such a direction that head should go into flexion and not in opposite direction. Okay, if you give it like this, then what happens? Head will go for extension. You should give it over the occiput so that the head will go into flexion and delivery will be easier. Fetal back to always kept anteriorly. Fetal back should always be kept anteriorly. Okay, if you put it posteriorly, it becomes like face presentation or mentum, which can never be delivered. So you should keep always fetal back anteriorly. Cover the body of the baby with dry sterile cloth. As and how it is coming out, you should keep covering with a pre-warmed towel so that you prevent hypothermia. Free loop of umbilical cord should be prevented from compression. So what you should do, you should put it to the side of the vaginal introitus, so along the side of the baby, so that it is not compressed. Now that you know about the spontaneous breech delivery, what is the assisted breech delivery that you want to know? Let us see, or you have to know. Let us see. See, when the breech presentation is there, as we already told, unless the delivery of to the umbilicus, you should not do any manipulation. Never push or never pull. Okay, once the baby is out so much and the fetus has a frank breech, okay, so the leg is extended at the knee joint, the limbs are not coming out. That is the first place you start your assistance. Till the umbilicus is seen, you be quiet, and then once you see it is a frank breech, then when you do just like you do internal examination, you hold your fingers and then go to the popliteal fossa. Okay, and when you tap at the popliteal fossa, what happens? The knee gets flexed and the foot comes in your finger. Okay, then catch hold of the foot and pull it down. Okay, that is how you deliver the limbs in case of a frank breech. This is called Pinard's maneuver. How to remember is P for Pinard's and P for popliteal fossa. So for limbs it is Pinard's maneuver. Go tap at the popliteal fossa, the knee which is extended will become flexed and the foot comes in your hand, hold at the foot and pull it out. Limbs or lower limbs are delivered. Then what happens? Move your fingers along the thigh up to the popliteal fossa and push the knee laterally, and this will flex the knee and bring the ankle down. Hold the ankle or the foot down and hold it, and hold the ankles between the fingers and pull the leg out. This is your Pinard's maneuver. Then the baby is somewhat descended. Now you can see the shoulders are being delivered, but then the baby's arms are not yet delivered. How do you know whether the arms are extended or by the side of the body? Based on the winging of scapula. You have already read in your anatomy so many classes. This is called as winging of scapula. When you extend your arms at your shoulder joint, the scapula is wide away. When you can see at the back of the baby, where if the scapula is wide away, that means the hands are extended at the shoulder joint. Or even in cases of nuchal arm. What is nuchal arm? When the baby's head is behind the head. Okay, that is when you call it as nuchal arm. Lies behind the neck like this. If the baby is holding like this, then this is a nuchal arm. Okay, and if the hand is extended like this, the scapula will be wide apart. That shows as winging of scapula. To diagnose the extended arms, look for the winging of scapula. See if the medial borders of the scapula are parallel or to the spine or not. If not parallel, then arms are extended. In this photo you can see they are parallel. That means the hands are not extended. In this photo you can see the arm scapula is separated. There is winging. That means the hands are extended. So now that you have diagnosed that the hands are extended, now you want to know how to deliver the baby's head. This is by Lovesitt's maneuver. See what happens if this is the pelvis, and you have delivered until the shoulder. Now the shoulders or the arms have got stuck. Now if it hinges behind the pubic symphysis and it is not getting delivered because of extended arms, then what you should do? You should see the pubic symphysis is always lower to the sacral promontory, and in the sacral fossa the space is more. So what we should do is rotate it by 180 degrees and make the anterior shoulder posteriorly. That time what happens? The anterior shoulder goes back and then the space is less. Again you rotate it back, then it would have crossed the pubic symphysis and you can easily deliver the shoulder. First rotate it 180 degrees, then the anterior shoulder goes back, then again rotate it back, the posterior shoulder is come here. Now it would have crossed the pubic symphysis. Either you can deliver the posterior shoulder. If it is not rotated, you can rotate it back so the anterior shoulders comes even more below and you can deliver the fetal shoulders. Now what happens? The next step is the fetal head. Now you delivered the buttocks with your Pinard's maneuver, you have delivered the shoulders with your Lovesitt's maneuver. Now comes the most difficult delivery, that is after coming head in breech. Okay, because everything else is compactable and all, but the head is not so much compactable. It requires enough space as it requires. So we have three techniques which are famous. Okay, one is Byrne-Marshall technique, Mauritius smelly weight maneuver, and Piper's forceps. These are most popularized and most effective techniques to deliver the after coming head. Firstly, let us know about Byrne-Marshall. Okay, once the anterior shoulders or the shoulders are delivered, make sure that the back is always anterior. Now the occiput would have hinged behind the pubic symphysis, and now you want to deliver. You should never pull. If you pull, what happens? Head will go for extension and it can never be delivered. Okay, so now that you have come up to the nape of the neck, you can see up to the nape of the neck. The head is there here. and you can see up to the nape of the neck you have delivered. Now what you should do, bring the patient to the edge of the table, maintain the suprapubic pressure. See, the suprapubic pressure should always be such that the pressure downward so that the neck will go for flexion, and you should not give pressure like this in the suprapubic so that neck will go for extension. You should always give a suprapubic pressure so that the neck will go for flexion. Okay, it is given like this so that the neck will go for flexion. Then allow the baby to hang on its weight. Okay, now the baby is come out, it is hanging on its weight. When the nape of the neck or this hairline is visible, that time both the feet are held. Okay, now you can see the nape of the neck. So now we hold both the feet in the hold both the feet like this. Okay, you hold both the feet. You can see in the figure also, baby is hanging on its weight like this, you holding like this, and then you make a long arc towards the mother's abdomen. Hold like this, and then you will make a long arc towards the mother's abdomen. This is how the head is delivered by flexion. You can see the head is now come out by flexion. This is your Burns-Marshall technique of delivering the head. This is most effective and most easily to be done, can be done also. Then comes your Mauritius Meliviate maneuver. Here what we do is, the baby's head is hung like this. You are seeing the nape of the neck. You put your hand like this and support the baby's weight, and then you will keep 2 fingers on the baby's 2 malar prominence. Okay, you can see the baby's malar prominence. Internal examination you have done, and you are keeping 2 fingers. One is your index and one is your ring finger on the baby's malar prominence. The other hand, initially it was told by in the Mauritius Meliviate, keep in the mouth and then you will flex the head. This helps at the flexion. You will do like this, and the baby's head will go for flexion. It will come out easily. So this is one. But now the modification of this or modified Mauritius Meliviate is that you don't keep inside the mouth. That might cause choking and gag reflex to the baby. Keep at the mentum or the chin of the baby and then flex it. You flex like this. You will flex. See, you can see the head is getting flexed, and then delivery of the head by flexion. So much you are learning about the different mechanisms of fetal head delivery. Do you know who is? He is the one. He is Mauritius Meli. He is the person who gave us this maneuver also after coming head in breech delivery, and also he is the person who applied forceps, first person to apply forceps for breech delivery. Okay, the Piper's forceps, he is the first person to apply the forceps to do the breech delivery, and also he was the person who told all the mothers on their legs walking around in labor deliver faster as they have good contraction and there is good descent than the mothers who lie down on the bed for pain. If you make them ambulate and mobile till they enter into the later stages of second stage, there is good uterine contraction and good chance of vaginal delivery than the person who is lying down on the bed. Coming to the last maneuver of delivering the fetal head, this is how we do for the forceps or Piper's forceps. It has a double curved blade, but the shanks are very long and handles are depressed below the arch of the shank so that the fetal head is delivered. It will be delivered by flexion. Application of Piper's forceps employing a towel sling support, and the forceps is introduced from below the left blade first is introduced. Always the left blade is introduced first, even the outlet forceps also. Prognosis with breech delivery depends on the breech presentation. Mortality incidences with breech is 25%, with non-breech is only 2.6%. Congenital anomalies are also quite common in breech itself than with non-breech. Birth traumas are also quite common, like brachial plexus injury causing palsies, okay, brachial plexus injury, bladder injury, long bones injury, sternocleidomastoid injury, spinal cord or hyperextension of the fetal head, liver, adrenal glands injury. Because you are holding the fetal abdomen and trying to pull, no, that time you have more chance of injuring the soft tissue also and hard tissues also. Asphyxia is also quite common, firstly due to compression of the umbilical cord leading or due to cord prolapse per se. Umbilical cord compression and cord prolapse are quite common, which can lead to asphyxia of the fetus, and delivery of the fetal head is delayed for more than 8 minutes, then also the asphyxia of the fetus is quite common. What are all the direct indications where you have to take for cesarean section in breech presentation? It happens in a large fetus when the fetus is more than 3.5 kg, hyperextended fetus, hyperextended fetus or stargazing appearance, as we already told. Then footling presentation, where chance of cord prolapse is almost 17%, and any degree of contraction or unfavorable shape and restriction. Okay, like platypoid pelvis we would not prefer, we are told, and contracted pelvis is there, we would not prefer for vaginal breech delivery, we would directly take for cesarean delivery. Previous perinatal death or child suffering from birth trauma. Okay, all because breech delivery itself can cause lot of birth trauma, asphyxia to the fetus, injury to the long bone soft tissues, so we preferably would not be doing. Uterine dysfunction is there, like dystocia and all is there, then also we will not induce the labor vigorously as we do in cephalic presentation and breech, because when we do that, more chance of head going into extension and delivery of the fetus is difficult. I hope now everything is clear in your mind, how the mechanism of labor happens in breech presentation. Thank you for listening. If you have queries, you can get back to us. Thank you.